burned out, and we still are, by menial tasks, and such as documentation just for billing, instead of focusing on our patients. So saving hours of our day by using these tools has really made a lot of a difference.
In a recent interview, CancerNetwork spoke with Dr. Arturo Loaiza-Bonilla, System-wide Chief of Hematology and Oncology at St. Luke's University Health Network, about the impact of emerging artificial intelligence-powered technologies on clinical practice, highlighting relevant literature performing real-world analyses of these novel technologies with established standards of care. Just to start, how has the emergence of AI-powered technologies impacted your practice?
Yeah, so AI has taken all of us by storm. We have seen almost daily releases of new tools, new news about the different stakeholders, since the advent of ChatGPT and others. So we are still in the process of learning, but it has my practice itself. I'm an AI enthusiast, so we're trying to incorporate as many of those algorithms as possible in my daily basis. So it's really changed my approach to oncology, particularly around what we call like precision medicine. In clinical trials, I have been doing it for several years in clinical trial matching, from a patient-centric perspective, because all that is data organization. So if we can use those technologies to summarize the patient notes, emerge biomarkers that the patient was tested or not, and then find opportunities for optimization in treatments, or at least make my life easier documenting, has been a dramatic shift in how we approach these tools to make our lives easier. We were burned out, and we still are, by menial tasks, and such as documentation just for billing, instead of focusing on our patients. So saving hours of our day by using these tools has really made a lot of a difference. And we're learning now that is not, as we know, oncology is one of those multidisciplinary specialties where the patient is the center of the whole experience, but we have radiology, we have pathologists, we have surgeons, we have genetic counselors, labs and processes around that, infusion chairs, clinical trials, and all of them have been touched by the AI Cambrian explosion that has been happening over the last couple of years. So the focus now is how we integrate things that make sense to the patient, to the use cases, to make our lives easier, and that we can trust those AI tools in a meaningful way, so we can devote more time to talk to patients, to be more empathetic, to really go into the vocations that we went for, and see what is the ground truth that we can leverage to be hopefully better physicians and become not only better human beings, but also trusting ethically that these technologies are going to be helping us in our daily practice.
Okay, thank you for the rather comprehensive answer. I feel like we got off to a very good start there, so I'll move right into our second question. Are there any ongoing clinical trials evaluating the application of AI in clinical practice that you would like to highlight?
Yeah, so one of the things that has been emerging from this is many of these tools are released as FDA approved or something that you want to test, but many of them have not been compared to reality. Many of these solutions can be important, but we need to have cross comparison with what happens when we have the AI tool versus the AI plus the clinician versus the clinician alone. And the first a few studies that have come up, at least with some results and things that I'm interested about, is on the diagnostic side. So just a few days ago, we heard from this study called randomized clinical trial called the MSEd clinical trial that was published in Lancet, where it basically showed that mammograms digitally assisted by AI were able to detect with optimized recall compared to the radiologists on their own, so making us more efficient. So that is now leading, for example, to there's this another study that just about to launch in the UK called the EDITH trial. We still don't have the the full details, but it's one of the supposedly announced by the UK government. One of the largest AI prospective evaluations in mammography. So they plan to enroll 700,000 women in 5 AI platforms. So just not one AI platform, but 5 across 30 NHS sites. And the government is giving actually money to fund this. And this is all based on the MSEd trial from Sweden, which is basically the precursor study to this, that showed that the AI increased cancer detection by mammogram by 29% compared to standard screening. And also reduced the interval cancers by 19% at 2-year follow-up. So very promising, showing basically a non-inferiority to double reading in AI, maintaining basically a rate of 6.1 cancers per 100,000 per 1,000 screens versus 5.8 manually. So I know you say, 0.3, but if you compound that by the hundreds of thousands of mammograms we do, that really helps a lot of patients. So I'm interested to follow those studies. There's other analytical as well done on the digital pathology space, and other things are happening that I feel are relevant would be kind of on utilizing the tools and comparing one versus the other. So I know the vendors of ambient AI are doing some of those studies as well, comparing internally with real world data how patients do feel with the ambient AI experience compared to those who are just seen by the physician without the help of those tools. Many of them integrated to the EMRs. So Epic is already integrated with DAX, for example. Abridge is also working with Kaiser Permanente for that. And we also know that Oracle, which had Cerner, another very large EMR vendor, they are actually intending to do an AI first EMR. So exciting times to see which one comes to be the one that helps us the most to be better physicians and take care of our patients.
Okay, thank you for the response. You went into quite some depth, covering a number of modalities there. So thank you again for that comprehensive answer. I noticed skimming through your blog that you mentioned the use of GPT-4. How does the use of GPT-4 change the way clinical trials are conducted?
Yeah, so for those who are not as familiar, so GPT-4 is just that is generative pre-trained transformer. That's the GPT stands for, and it's just telling you that this is a pre-trained language model based on a bunch of data. And what we have seen over the years is that the evolution of those GPTs, so it started with GPT-1, 2, 3, 3.5, 4. Now we have the O or OMNI LLMs, and now we have O3 mini, and others coming up like DeepSeek R1 that take everyone by storm because it was open source. So we're still learning how to adapt to all those models. However, the good news is that we have already seen the benefits that could be derived by using these LLMs. So in clinical research, something that I particularly use, for example, at Massive Bio, we were using technology and AI to solve this clinical trial enrollment paradox, which is we have millions of cancer patients diagnosed every year, tens of thousands of clinical trials actively recruiting, but very few people actually are aware of the trials. Fewer enroll in trials themselves, and half of the trials have issues recruiting. So it's a complete paradoxical situation. So we wanted to solve that by using AI, and now with the advent of the transformer technology, these LLMs, we can basically really fast forward the process much easily. So instead of we presented some data in ASCO where we had a consortium of multiple pharmaceutical companies giving us their protocols. and we matched them to a real world data set of patients with cancer in the community that were looking for trial options. And we found that with using these LLMs, we reduced the pre-screening across 180 different parameters to basically 1 hour compared to 18,000 hours. So the equivalent of basically 99% efficiency, which now can be devoted to taking care of patients with a shortage of research coordinators and folks interested in doing the data processing. This is exactly where AI and this transformative technology is going to make a difference. We don't need to have any more data analysts. We have now agents that do this, and we can specialize agents for different tools. So, for example, I have in the company we have one model or one agent that does the analysis of the records as they come in from the EMR or completely unstructured. We have another agent that does the full pre-screening on clinical trials, and the other one that does the full pre-screening, full analysis on the data points to structural information. And then we have an agent that is able to find biomarkers. So all those things are really changing how we do clinical trials. And the idea is that it becomes almost like an end-to-end hub and spoke situation where the patient can be enrolled in these decentralized pre-screening hubs. Once they're diagnosed, they just follow the funnel. And the same way we're using Instacart or Uber or you name your app that gives you stuff and utility, we can use it for clinical trials and research. So if you need a clinical trial, you need to move, you get activated in real time because all the data is in flux. And as the trials open and close, you have the ability to know what's happening around you. And I think this is a trend that the sponsors, CROs, they're all finding compelling, including the state society. So I'm very excited to see on the next few years how this technology is fully integrated with community-based sites, and patient-centric digital technologies are going to change how we conduct research closer to the patient's home.
Once again, very remarkable insight. Thank you again for speaking to that end. Moving on, can you describe different digital pathology and multimodal approaches that you believe have the potential to transform clinical practice?
Yes, as alluding earlier in the conversation, we know that diagnostics and pattern recognition is something that AI is pretty good at. So it started recognizing, cats and images of things, and we knew that AI was something that was going to impact us all when the models were able to, solve this challenge called, the ImageNet, challenge when it came up, and this AlexNet came up and was able to be better than humans. Now we have the ability to, post a picture, and even any of these tools is able to recognize and describe it in full detail. So pathology being also, something that would look at patterns, with our brains, can really help us in using computer vision, doing segmentation of those what we call the kernels, which are like the pixels that comprise images on pathology. When we do whole slide uploading in these models, is very promising. So we can go from spatial transcriptomics to single cell sequencing. We are now seeing a major impact on this. So, for example, you're always curious about what patients may benefit from immunotherapy because we have, changes in the microenvironment based on lymphocytes or subtypes of lymphocytes. Now we're using digital pathology to give us those biomarkers that sometimes were unknown to us. Like they're just giving us new insights on things that we were not aware were making an impact on response to treatment. Our eyes are, amazing tools that we evolved them for, all in the history of life. But we know now that when you put, billions of data points in terms of, visual pixels, we can start seeing things that even our eyes and brains typically do not process. I mean, they may process it, but we don't surface them because we don't know they exist. So now we can do H&E slides, basically, and they can detect if that sample has positivity for not only a biomarker such as HER2 or PD-L1, but even beyond, like mutational status. Right now, we don't even know how, but the system is able to detect those things, and even prognostics. So if depending on where the collagen fibers are aligned in a breast tissue sample from cancer, we may know the prognosis of that patient. So things that we never even thought were possible before, now we can find them with this multimodal approaches in pathology. The idea is to combine pathology images with genomics and clinical data, so we can develop these multimodal predictive and prognostic approaches, and we call it the foundational models, which is having tons of patients put on their this analysis and being able to start putting those clusters of patients and data together. So there's a number of emerging platforms that I think are key. For example, one of them is Path AI is doing that. The other one is Page AI. We have very good efforts done by pathology groups, digital pathology and computational biology. So, for example, Dr. Mahmoud at Dana-Farber, they just brought this new foundational model. So, for example, Path AI had 30 million deep learning annotated slides, and they do multimodal fusion H&E with IHC and RNA sequencing. They were able to find 22% higher PD-L1 sensitivity in, for example, bladder cancer versus manual reads, and they clear by the FDA for 15 biomarkers. Page had a 1 million slide foundational model. They came a bunch of patients or samples from Sloan Kettering. They trained them with Microsoft Azure, which is now also part of the Microsoft Fabric, which is this number of platforms that you can use for healthcare. And this spatial transcriptomics was able to integrate it, and now they have an FDA clear prostate cancer detection that has 96.8% accuracy, called Page Prostate, and they have a 70% reduction in false negatives. So it's helping for that high-risk detection of prostate cancer. And the one I mentioned from the Mahmoud's lab called Threads is a molecular-driven multimodal model. They have all these whole slide images paired with genomics, and they do the transformer model of attention, but they do it at the gigapixel level, which is how the uniqueness of them. And they basically they outperform like about different tests, including rare tumor prediction. And the AUC, which is the area under the curve, it was closer to 1. So that you wanted to get closer to 1 always. It was 0.93. So basically very, very significant. So all of them are telling you that across 17 plus tumor tissues and bunch of slides, millions of them, we can build these foundational models that are going to, in the future, be standalone and part of the baseline of how we make predictions for patients with cancer. The key thing now is making sure that we have an accurate representation of all kinds of patients, because as you can imagine, data, it could be skewed one way or the other depending on the population of patients, and we all have different microenvironments, different germline and somatic genomics. So I think this is a call to action to build, really huge foundational models, maybe in the billions, the same way as LLMs were billions of tokens of features of parameters. We can do the same in the billions of gigapixels or clusters.
Okay, thank you again. That all sounds quite promising. Is there any relevant data that speaks to the benefit of AI use in clinical documentation? I think you might have touched upon that, but I figured I would ask anyway.
Yeah, absolutely. So clinical documentation is a major pain point for us clinicians. We get tired of doing an extra click or putting an extra note for something that we know is self-evident, but if it doesn't get put in the system, it gets you don't get billed, and that's the nature of what we practice. So now we're trying to rely on data summarization, the same process that I do for clinical trials. We can do it as well for usual standard of care. But also we're now relying on new things called ambient AI scribes. So there's different companies doing this, Microsoft, Abridge. The idea is that they want to reduce documentation time while we still talk to patients, right? So The studies show that these tools may decrease burnout to a certain extent. To how much is hard to quantify because everyone has different level of burnout, right? But for example, at Stanford, which is always at the forefront of AI tool implementation, they improve satisfaction scores, 90% saying they feel better about the whole process. There is some evidence from the DAX or the Dragon Ambient Experience Copilot, which they say that decreased the median note writing time from 19.5 to 1 hour per 100 patients in family medicine practices. So that's a little bit different from oncology. So there's some nuance to how we do this, not pun intended, because they also call the product nuance. The speech recognition EHR integration was actually pretty accurate. So that's the promising part. So it can be up to 97% in ER documentation. So they were able to decrease charting time by 50% plus. When they put in the ICU setting, there was decrease as well in the time for those alerts. So that helps as well for documentation of things that we need to document for the patient care. And if we integrate it with multimodal approaches, I think it can help us even further, right? So I think that the promise of all this is not only time optimization, but quality assessments that help us to find opportunities for things that we are missing that we may not remember, but the system gives us very unique frameworks that we need to follow, and hopefully help us so we don't have to do extra time on that. In kind of putting all this together for appropriate burnout mitigation. So we want to decrease burnout. So there's a couple of studies. So this JAMA trial revealed about like early AI adopters. They saw no time savings, about 44% of them. But that may speak that we need to be some fine tuning in there, right? That we need to optimize to the time invested in saving by documentation. We don't invest it in more administrative tasks, right? So that time is off. We should be focused on actually taking care of patients. But in technicality, you look at there was this analysis of 36 studies in 2024 that found this AI increased documentation, improved accuracy between 22 and 29%, and was able to decrease the time that we spend with this and with a very good accuracy. So now the focus is, let's fine tune it for the specialty use case in surgery, radiation oncology, radiology, and medical oncology. And also make also that the fact that this is not going to take more time than we used to. So more to follow, but I think that the future is there. We needed to start, and we are in a good foundation at this point.
Hey, thank you for outlining that. How might large language models be employed to enhance clinical practice for patients? Something that you also previously covered, but maybe you have some more insight.
Yeah. So as mentioned, LLMs, language models, they really have made a lot of a difference in clinical practice, but also even for medical education, for example. So now we know that these LLMs can literally pass every single board exam that we may have at a high level. Even without specialization, now we have the O3 model that was just released. There's this test called the last test of humanity, basically. So it's called the humanity last test or last exam. And in the past, no LLM was able to go over like 10%. This one is 26%. So we're getting close to it. And this is a very, complex exam. So of course, medicine is very complex, but we are task-oriented, right? Not everyone does everything. I don't do neurosurgery. We need training for that. We need different agents for that. So now we are focusing on how we can do LLM to optimize, for example, patient education, how we can use it for translating complex jargon into accessible language to our patients so they understand what we're telling them, and there's much more adherence, more trust as well, leveraging the empathetic component that, interestingly enough, it was taught by us. So if you say, oh, LLMs are nicer, they're more empathetic than physicians, well, if you give me time, I can be as empathetic because we were the ones who trained the systems to be like that, right? So it's not that it came out of nowhere. The compositional generalization, which is what we call that the systems, the AIs learn something new that was never thought, it doesn't still apply to empathy. As far as I know, is all coming from us humans. So the idea here is that we want to use this to synthesize information, to be better summarization, give us more insights on things that are missing, improving clinical decision support, and making sure that we can do simulated cases where we can say, okay, I have seen this case before, like a tumor board, and see how those patients did based on where the patient fits. So clinical practice can be optimized by multiple ways. I think that the difficult part would be more to the quantification of it, right? So because if the LLMs and all these models and algorithms are helping the patient getting access to the physician on the phone, right? Because we have an agent that answers the phone and is able to talk to you and get you to the operator where you should go. And then it helps you to make your infusion time, better because it's able to look at those numbers, and it's able to, order the test for on behalf of the physician. So they just click a button, and then you talk to the patient more time because you have the time to do so by documentation, and also helping the radiologists and the pathologists and the radiation oncologists to do better, auto contouring during the time they're on the radiation suite. And it helps the surgeon to be more accurate in terms of margins, and the pathologist to detect those margins or the biomarkers faster, and then you get the right drug in the clinical trials. All that is compounded interest, right? So I think the impact is going to be really big, but we may need an AI to quantify for us because there's so much complexity, and we live in our little silos that to see the use cases as a whole is a little bit more complex. So we need that kind of NASA command center approach to look at the implementation of AI in clinical practices, because I feel that there's a lot of things that we can leverage for the positive end. And one point I wanted to make this is just recently there was this New York Times editorial by Eric Topol, and the author was also from this professor who works, I forget his name, but literally the idea was, is the robot ready to see you in clinic? And that was the analysis was that sometimes AI is better than us, and we had to accept that fact, but we had to try to relinquish some of those things so we can focus on other things that is going to be harder for machines. So that's called the Moravec's paradox. That is a concept from the 1980s, where basically things that we have evolved over millions of years, which is relationship, certain things we are much better than in finesse of touching and doing procedures than doing mathematics, which is a much more recent concept for humans, right? We didn't have the evolutionary pressure to be good at math, right? So, but LLMs can do that much faster and at the same ability or even further. So we want to, Moravec's paradox being resolved with us not being with the belief that we are better than the machines in certain tasks. There's certain things that we're better than that. We don't use a telegraph anymore. We use a smartphone, right? So that we wanted the same for this. So let's see how it goes.
Thank you for outlining the paradox there. Definitely something that I did not come across upon my reading of your blog, so that was a nice little supplement there. You gave a very comprehensive sort of overview of the current AI and large language model landscape as it relates to clinical practice. But I guess my final question to you is there anything else that you would like to highlight regarding the application of AI into clinical practice?
Yeah, so well, I think and a point is, we are I'm team human, but an AI enthusiast. I believe that AI is not a replacement for us; it's a force multiplier. The same way that we have agents that does certain things for me. I still can do grocery shopping myself, but I may use an app instead because it's easier, convenient, so I can use my time to take care of patients, so I don't have to drive to the supermarket. Someone else can do it for me. In this case, an agent can do that ordering for me. The true value of that is that there's going to be some tasks that we should relinquish or give away to AI, and there's some others that they're going to be part of the human experience, and some others that we need to combine AI with humans to make it better. I doubt that there's going to be 100%, AI robot that is going to be a physician, because the skill set to be, for example, robotics, to be a full-blown doing surgeries for us, or having the empathetic relationship with a patient, or even giving them comfort when they are in the time of need, or understand the social determinants of health of a patient, is not going to be solved by an AI or a robot with an algorithm inside, no matter how advanced it is. That takes a lot of time. We may get there at some point, but not over the next 10, 50 years, I think. The true value is in augmentation. Whether faster clinical trial matching and help us to be a model that helps the patients to get access in real time, sharper diagnostics, such as we talk about prognostication and multimodal approach, so we don't waste money and resources on a patient whose time is the only major asset they have. We don't want to waste their time, right? That's the thing we cannot buy. So we can reinvest efforts into physician time, patient time. It's a very well invested effort. Reducing the communication burden, making streamlined processes, so we only do the same thing that we're doing here together, which is just talking, right? And exchanging information meaningfully, that help us to get to a better place as a whole, as a cancer community, society as a whole, that trickles down across. So the key is, I think, ethical deployment, continuous validation, so make sure that it is representative of all of us. I want an algorithm that knows me and can do multimodal. Now we have potential quantum computing, or we have these very advanced agentic models that are able to understand all these different nuances in real time and run simultaneously in a parallelizable approach, potential journeys that I should run, so at least I can do an informed decision. And making sure these patient outcomes are always the forefront of what we're doing, so we can advance science. And as Larry Ellison was saying, maybe perhaps in the future we just get diagnosed with multimodal scan that detects cancer before it shows up, with a blood draw and a scan, and we can use the LLMs and all these models and transformers and beyond, like AlphaFold and things like AI-based companies for drug discovery are doing, like Recursion and others, finding molecules that are really matched to that specific pocket of that area, and generate a vaccine by mRNA or other technologies emerging at scale. So you take it off the shelf, take it, and you can target multiple agents, and then be done with your cancer before it even becomes a problem. That would be amazing. But for that, still a lot to work.